Thank you, Steve, for the very nice introduction. I'm very honored to be invited to this webinar. It's quite challenging to talk about the health systems in 12 or 15 minutes. So I will try to be very brief and talking about the major issues and the challenges and the initiatives. I'm Dong Roman Xu from Sun Yat-sen University, and our center focuses on primary health care interventions. So this is a health system is an area that we have huge interest in. This is a very popular health system framework. There are many components of health system. They are called control knobs, sometimes called building blocks of health systems. Those are on the right-hand side. Those are working together to achieve the intermediary outcomes and also the ultimate outcomes in improving health status, providing better financial risk protection, and improving consumer satisfaction. So for today's talk, I will focus on some of the building blocks of health systems here, so which can give you a good context for Yaolong and Qi for their talk in the following. The first thing I'd like to address is the financing of care in China. In China, there are essentially three social insurances which are financing the care in China. The insurance including the one for people who have a job living in the cities with a formal job, which is a mandatory social insurance. Employer and employee pay premiums for the insurance. The second one is for the people who are living in the city but without a formal job, which is a voluntary social insurance, essentially financed, subsidized by the state tax. The last one is a very large one. It's for the rural population, which is essentially the voluntary insurance heavily subsidized by state tax. Even though the last two insurances are voluntary, majority of the people do participate in the insurance. And amazingly, because China just started its insurance for rural population in 2003, so in just over 10 years, China has successfully achieved almost universal insurance coverage. And now more than 99% of the Chinese residents have some type of social insurance. However, major challenges continues. Those challenges include the out-of-pocket payment of the Chinese residents remain to be very high. And there is a huge inequity in benefits packages across the three insurances. So for people, if you are in the urban insurance, you have a much better benefit package than the rural ones. And there is a very high, now there is an effort trying to integrate the three schemes. The current effort right now going on is trying to integrate the insurance for urban residents without a formal employment with the rural insurance. Maybe in the more longer term, the three insurance will be fully integrated, but currently only the last two. So how the care and the clinical services are paid for in China? In China, predominantly, the inpatient and outpatient services are paid through fee-for-service. This is the predominant payment method, and the fee schedule are set by the government, and the fees for clinicians' consultation are artificially set very low. So if people are familiar with health systems, we all know fee-for-service is the worst payment mechanism because it creates a very bad incentive for the clinicians to overprescribe medicines and technologies and unnecessary services. So now in many places of China, the government has a major priority to reform the payment system. Right now it is going on trying to change the fee-for-service into some sort of bundled payment mechanism, including many provinces are piloting DRG, diagnostic-related groups. Some places are also trying global budgeting. Some places are trying single case payment. So all sorts of bundled payment mechanism have been piloted. So other efforts including trying to reduce incentives for physicians and the hospitals to overprescribe drugs. In the past, revenues from the drugs normally accounted for about 60% of the revenues of the hospitals, which was extraordinarily high because hospitals can charge 50% markup on drugs sold. The current effort is to remove all of the markup of drugs, so to remove the incentives of the hospitals and the clinicians to make money on drugs. Chinese government is also trying to correct the price distortion in a way trying to increase the payment for physicians, but decrease the payment on some of the technologies. So in order to better reflect the labor cost from the physicians and the clinicians. In terms of the health service delivery system, just 1 second. So in terms of the human resources for health, China has a very large number of clinicians, including doctors, nurses, paramedics, and other allied health professionals. So the number is not a big issue for China. However, distribution is a big issue. The human resources for health are equally distributed from west to east and from urban to rural areas. The maldistribution of human resources for health is a big issue. And also another big problem is the training of doctors are not standardized. In China, many people are called doctor, but a doctor itself refers to many types of clinicians. And the training includes 2 years training, 3 years training, 5 years training, 7 years, and 8 years. So when you are going to see a doctor, you are actually seeing many types of people with a very diverse clinical background. The current effort in China is trying to standardize the medical training. So in the future, the 5+3 are intended to be the mainstream of training for physicians. So 5 years medical school training after high school, plus 3 years residency training, so they become general practitioners. So 5+3 will become the mainstream, while some of the 8-year program will continue, and some of the 3-year program will also continue to provide clinicians for the rural areas. In terms of the service delivery, China has a healthcare service delivery system which is very much hospital-centered. And majority of the hospitals in China are public hospitals. They are absolutely the dominant player. For instance, in some provinces, I just came from my trip to Guizhou province yesterday, and we visited many hospitals over there. In Guizhou provinces, even though the number of private hospitals are almost on par with the number of public hospitals, but the volume of services the private sector is providing is very small. So predominantly public hospital is the largest player. However, even though majority of the hospitals in China are called public hospital, they are more or less like the non-profit hospital, a private non-profit hospital in United States, because although they are called public hospital, they still need to earn money from their clinical services, and the subsidies from the government only account for less than half of their operation. And the private hospitals are just emerging, but still very small. And very often, majority of the private sectors are considered inferior in quality to the public sector, which is very much different from other countries. Another very distinctive feature of the service delivery in China is that there is no gatekeeping system. So for a patient, basically, you can go to see any specialist as long as you can get the registration and appointment. So no gatekeeping, no primary care physicians helping to make the system more efficient is a big issue. So from the cartoon on the right-hand side, you will see many people are going to the big hospitals, and those big hospitals became very overwhelmed and overcrowded. But the smaller hospitals, community health centers were deserted and nobody going to visit. So the current effort is for the past, since 2009, in the new round of health reform in China, the effort is trying to strengthen primary healthcare system. China is trying to establish the family doctor contracting system and introducing family doctor to the communities and have all the families have some contracting with a local doctor. Another big effort is trying to build up something called the Yigongqi, which can be roughly translated as an integrated delivery system. In the integrated delivery system, the government package integrate county hospitals and township health centers and village clinics and make them into an integrated delivery system. Then government pay financing the system, and the system distributed further the budget among the system itself, and trying to build up the referral system and gatekeeping system within the integrated delivery system. This integrated delivery system is a big thing which are piloted in many provinces in China, which is currently going on. Another effort China is trying is, in addition to the primary health care, they are concurrently providing something called the free public health service package. In the free public health service package, which are delivered free to the residents without any charge, they include in some of the things which are very often in the primary care setting, such as the management of hypertension, the management of diabetes, and the management of severe mental disorders. Those are directly delivered by the government health institutions. So in this last slide, I'm trying to give you an example of how those efforts are going on. This is called the 686 program, which is the universal mental health coverage for the Chinese residents, which is part of the Chinese public health package. So basically, the doctors, village doctors, screen the villages in the community. So people who are screened with, say, some of the major form of mental disorders, like schizophrenia, they were sent to lead the county hospital psychiatrists. Those psychiatrists are very often internists, transformed psychiatrists. So they are not the same kind of psychiatrists who have the same level of education as in the West. So those psychiatrists then confirm the diagnosis, then those people are put on the management plan. Free medicine are given to those people. Psychiatrists travel to the communities and meet those people every 2 months to give consultation and give free medication. In a local township hospital, there are mental health administrators who are integrated into the primary care system locally, and they provide every quarter home visit to the families of those patients. They also give physical checkup every half a year for those patients in the township health center. So the village doctor, township mental health administrator, and the county psychiatrist working in the team, which is an example of both the vertical system, which is a disease-oriented mental health program, but also integrated with the horizontal system. This public health package system also works for diabetes and hypertension and other areas, which are part of the unique feature of China's primary care system. So I think this is very roughly some of the major issues and building blocks of China's healthcare system, including the human resources for health, how the care is organized and financed and paid. I hope this will give some of the background for the presentation for Yaolong and Qi. Thank you so much.
Thank you very much, Roman. was an excellent overview. I'm going to pass the control over to Yaolong now to start the next section of the discussion. Thanks for your patience, everybody. Qi is going to start off the next section of the discussion, and hopefully Yaolong is able to connect his audio in a little bit.
Yeah, hello everyone. Sorry for the technical problem. I will present on behalf first. Hello everyone. I'm Qi Wang and Yaolong. We will on behalf of the Chevidence working group. It's our great pleasure and honor to talk about the top 10 lessons about the developing and implementing novel approaches on how to support evidence-informed health systems in China. First of all, we'd like to thank Dr. Joe Lewis for giving us the opportunity to share our experience with the global audience. Many thanks also for Steve and Kaelan for the introduction and for hosting this meeting. This is our disclosure for interest. Yaolong is a methodologist from the Evidence-Based Medicine Center of the Lancome University. I used to be a master student at Lancome University, and this year I started my PhD studies in the Health Policy PhD program at McMaster University. Before we get started, I would like to make a quick and brief introduction to the place where we live and work. We are from Lanzhou City, which is located in northwest China. The Yellow River, our mother river, flows through our city. This is the city's night scene. Besides natural views, we have also a very rich local culture and cuisine. The most famous food are the Lanzhou beef noodles. It was created in 1915 and is well known all over the world. Lanzhou has over 1,000 beef noodle restaurants, and this city consumes about 4 million bowls of beef noodles every day. We also have a famous World Heritage Site, Mogul Grottoes. It is a great collection of ancient Buddhism art of China, located at a religious and cultural crossroads on the Silk Road. Our Lanzhou University is a key comprehensive university in China. It was founded in 1909 and contains 30 faculties and schools. In 2017, more than 7,000 graduates got their degrees from Lanzhou University. Chevidence, which was founded in 2009, is based in the Evidence-Based Medicine Center of Lanzhou University, which also hosts the Chinese Grid Center, the WHO Collaborating Center for Guideline Implementation and Knowledge Translation. Chevidence comes from the two words, Chinese and evidence, with a vision of better knowledge for better life. Our work is about to synthesize and assess research evidence, to produce evidence-informed recommendations, and to promote knowledge translation and implementation. Until now, we have published more than 100 papers in international and domestic journals, including in JAMA, Lancome, BMG, and others. Also, we have to develop more than 50 guidelines for organizations in China and abroad. I'm sorry, I think we spent too much time on talking about ourselves. Now let's get back to our topic, the top 10 lessons. I'd like to divide those lessons into 3 parts. Part 1 contains the first 3 lessons. We will focus on the evidence-based medicine organizations and institutions in China. In Part 2, we will show 3 examples from national health policy in China as important cases to show how the evidence-based medicine organizations have to strengthen health systems and support health policy. In Part 3, the last 4 lessons will introduce 4 typical evidence-based medicine programs in health systems that have been applied in practice. The first lesson we'd like to share with you is the importance and the roles of evidence-based centers in health systems in China. In 1980s, China joined International Clinical Epidemiology Network. After that, several leading Chinese medical universities and hospitals sent their faculty and clinicians to McMaster University in Canada to learn clinical epidemiology and evidence-based medicine. Dr. Qi Wang, the founding director of the Evidence-Based Medicine Center of Fudan University in Shanghai, is the first person who obtained a master's degree at McMaster. She was also the first to translate the term evidence-based medicine into Chinese. The translation is now widely accepted in China. The lesson invited Professor Qi Wang to write an article to introduce EBM in China in 2010. Sorry we couldn't see the movies. If you need the slides, you can get it by emails. Up to now, more than 20 evidence-based medicine centers have been established in China. 5 evidence-based medicine journals have been launched, and more than 50 textbooks have been published. The evidence-based medicine centers contribute a lot to health systems in China, not only because they continue to produce and disseminate the best available evidence, but also because they have become cradle of methodologists and evidence-based medicine researchers for the Chinese government and research institutions. The second lesson is now Cochrane China contributes to evidence-informed health systems. As we know, systematic reviews are an important source for evidence-informed health policy. Cochrane Collaboration is a renowned organization for producing and disseminating high-quality systematic reviews in the world. In 1999, the Chinese Cochrane Center, now called Cochrane China, was established in Western China Hospital. This lady, Professor Youping Li, is the founding director. Cochrane China regularly hosts workshops on evidence-based medicine and systematic reviews in China. More and more Chinese researchers and clinicians have received training and publishing high-quality systematic reviews. Yaolong also received his master's degree at Cochrane China, and Professor Youping Li was his supervisor. We have 2 figures. One figure shows the numbers of systematic reviews and meta-analysis published by Chinese authors in Guideline. It is increased year by year. The other one showed China's contribution to Cochrane systematic reviews, ranking within the top 5 in the world. High quality, of course, doesn't mean high quality. You may be concerned the quality of the systematic reviews authored by Chinese. However, this paper found that there were no essential differences in the methodological and reporting quality between systematic reviews from China and the United States. As a result, more and more health policy makers have realized the importance of systematic reviews and started to use them when making health policies and developing guidelines. The third lesson we would like to share with you is the Chinese Grid Center and the development of evidence-based practice guidelines in China. Maybe some of you are not very familiar with grid systems. It is a common, sensible, and transparent approach to grading quality of evidence and the strength of recommendations created by an international working group. These systems can help policymakers better understand and interrupt the results of systematic reviews and meta-analysis. It can also bridge a gap from evidence to recommendations and policies. So far, more than 100 organizations have endorsed or are using GRID, including WHO, CDC, Cochrane, and others. The GRID working group has set up 8 centers and 3 networks globally, and developed several groups and projects focusing on different topics. On September of 2011, we established the Chinese GRID Center at our Evidence-Based Medicine Center, which is so far the only GRID center in East Asia. This gentleman is Professor Qi Wang. He is the founding director of our center, the Evidence-Based Medicine Center at Lancome University. In 2010, he asked Yaolong to visit McMaster University. When Yaolong arrived at McMaster, he found he was the first researcher from China to study GRID and how to develop evidence-based guidelines. He spent half of the year there with 2 co-chairs of GRID working group, Professor Golden Guide and Professor Holger Sugarman. Later, Yaolong had the opportunity to work with Dr. Andy Oxman, which is the founder and former chair of GRID working group. When Yaolong left McMaster in 2011, Golden and Holger hoped that Yaolong would bring grade to China, and Holger came to Lanzhou to help establish the Chinese Grid Center. Over the past 6 years, the Chinese Grid Center has helped Chinese policymakers, health societies, and associations to develop a guidance for guideline development, and to publish textbooks on how to use grid and how to develop evidence-based guidelines. We also help Chinese guideline developers to develop clinical practice guidelines based on grid. This slide shows the 2016 Chinese clinical practice guidelines for the diagnosis and management of gout we developed together with Chinese Association. It ranked the top one among all clinical practice guidelines published in China in terms of visits to the online version, with about 1.2 million clicks. We were also asked to produce dozens of evidence-based policy briefs for the National Health and Family Planning Commission of China, formerly called the Ministry of Health. With regard to more information on the development of Chinese practice guidelines and the role of grid in them, we have a detailed discussion in the oncoming DMG paper at the end of this month. For the first part, we introduced 3 institutions and platforms which are producing and translating evidence for decision makers in China. In the next part, we'd like to introduce 3 cases from the National Health Policy of China where evidence-based methods have been applied in practice. As far as we know, one of the earliest national health departments that adopted evidence-based approach in their health policy is the China Food and Drug Administration, CFDA. In 2002, CFDA invited Professor Youping Li to give lectures and training about how to select and review essential drugs list. This is not only because Professor Li is the director of Cochrane China, but also because she was the reviewer of essential drugs list program at WHO, which is considered one of the WHO's most important projects over the last 40 years. This picture shows in 2004, the FDA released the updated Principle of Essential Drugs list, which highlighted the importance of the evidence-based approaches. In 2009, Professor Li and his colleagues published a paper titled Evidence-Based Selection and Implementation of National Essential Medicine Lists in China, to summarize the experience and how evidence-based methods influence and support the health policy decisions. The next case is similar to the evidence-based essential drugs list program. We'd like to introduce how the Chinese Center for Disease Control and Prevention started to develop its evidence-based decision-making for vaccines. This approach derived from the WHO and the US CDC. In 2013, China CDC invited Dr. Jonathan, who was the chair of the US Advisory Committee on Immunization Practice, to provide a training for the staff and officials in China CDC about how to produce evidence-based recommendations when developing vaccine policies. After 4 years preparation, just in last month, the Chinese government established a national advisory commitment on immunization practice, and the China CDC hosted an advanced seminar on evidence-based decision-making for immunization. It is considered as a landmark of evidence-informed immunization policy in China. Yaolong was invited to give the training courses to the committee on how to use grid to read the quality of evidence and suggest the recommendations. The third case is about the traditional Chinese medicine, which some of you might particularly be interested in. We'd like to talk about the China State Administration of Traditional Chinese Medicine and evidence-based decision-making. As you know, China is the only country in the world where Western medicine and traditional Chinese medicine are practiced alongside each other at every level of health systems. Traditional Chinese treatment accounts for about 40% of all healthcare delivered in China. The quality of TCM has therefore a significant impact to the Chinese health system. However, for a long time, TCM relied mostly on experience rather than evidence. Researchers and health policymakers have, however, started to realize the high-quality evidence is the critical way to have TCM to be accepted and used in more and more countries. In the recent years, well-designed RCTs have been published in leading medical journals such as the Annals of Internal Medicine and JAMA to show the effectiveness and safety of acupuncture for some diseases. China State Administration of Traditional Chinese Medicine requires TCM societies to develop practice guidelines based on scientific research evidence. Some TCM guidelines even use the grid system. In the third part, we'd like to share with you 4 evidence-based programs that contribute to the health systems in China. The first one is about using evidence to strengthen healthcare in rural China. From 2009 to 2011, the Chevidence group conducted a cluster randomized controlled trial to test whether mobile test methods could help communicate evidence-based recommendations to health workers in rural China. The results showed that test messages can be effective for transmitting medical information and changing health workers' behavior, particularly in resource-limited settings. The paper was published in the Bulletin WHO in 2002. Dr. Roman Xu, who at that time was the director of CBM Beijing office, witnessed the whole program. The second program I'd like to share with you is about the translation and dissemination of health system evidence in China. As we know, health system evidence is the world's most comprehensive, continuously updated repository, systematic views, and economic evaluations about the health system governance, financial and delivery arrangements, and implementation strategies. We started translating items in the HSE repository into Chinese translation in 2010. During these 7 years, we have translated almost 130,000 words. Nowadays, we use at least 30 hours every week for the translation to ensure the quantity and quality of the translation. Besides, we have disseminated the translations of HSE through publications, presentations in conferences and workshops, as well as society media in China. The translations are being continuously searched and used to promote evidence-informed decision and policies and strengthen the health systems in China. We are exploring to use WeChat, a very popular new social media in China, to improve the dissemination and uptake of HSE in China. In addition to the implementation of evidence, we are also concerned about the transparency of evidence production and synthesis. In China, we have 2 platforms to assure the transparency of research evidence. The first one is the Chinese Clinical Trial Registry, promoting the transparency and the reliability of clinical trial in China. As we know, the International Clinical Trial Register platform was established in 2008 by WHO. The International Platform for Prospective Registration of Systematic Reviews was launched in 2011 by York University. Based on our previous work together with researchers, health policymakers, and clinicians from the WHO, Grid Working Group, NICE, and ACP, our group at Chevidence launched an international platform for registration of practice guidelines. The platform aims to improve transparency in guideline development and prevent duplication, as well as promote the collaboration, dissemination, and implementation of guidelines. Up to now, there are more than 40 guidelines registered in the platform. Besides the transparency, evidence is expected in a more detailed and systematic way. Reporting guidelines can promote the standardization of evidence reporting, help policymakers or users better understand evidence, and promote evidence-informed health policy. There are different international reporting guidelines for RCT, systematic reviews, and their extensions. In China, for Professor Zhao Xiangbian and his colleagues issued the consult extension for Chinese herbal medical formulas. We have also launched an international program named RIGHT, aiming to provide a reporting checklist for practice guidelines in healthcare. 2 papers about the RIGHT program have been published in the Annals of Internal Medicine. RIGHT checklist has been translated into Chinese, German, Italian, and Japanese, and other language versions are under development. Just like Consort and Prisma, RIGHT is also not only a single checklist, but a family of checklists. So far, RIGHT program has launched 10 extensions, which include reporting in patient versions of guidelines, guideline proposal, conflicts of interest, and other topics and areas. This is the official website of RIGHT. We warmly welcome researchers and clinicians who are interested in RIGHT to join us to improve reporting quality of global practice guidelines. There are some pictures of Chinese young researchers with international colleagues and experts. Compared with former evidence-based medicine generations in China, they have more resources and chances to start or work in world-class platforms or research teams, and learn more from excellent scientists and experts all over the world. We believe in the future they will take greater responsibility and leadership, get more achievements, and promote better progress in evidence-informed decision-making in China. As a conclusion to our presentation today, we would like to thank McMaster Health Forum for this opportunity. We would like to give our special thanks to Dr. Jenny SDO, who is our best friend and honorable member of Chevidence, for his great comments and revision about the slides. If you have any questions or comments, please type the chat box or contact us by Twitter or email. We welcome you to visit our university and Gansu province, the hometown of beef noodles. Thank you very much for your attention. Thanks, Stephen.
Thanks, Qi. Just before I pass it over to Kaelan for his quick comments, I wanted to just, there was one quick question that we had from somebody, Qi, who was asking if you could repeat the title of the article, and it was one that I think you mentioned around insight number 5, and it was one you talked about being published at the end of the month. So if you could maybe either type that in the chat box or just share that with us, if you can remember which one that was, that would be great. And then I'll just pass it over to Kaelan for his quick insights on everything that's been shared by Qi and Roman before we move into a Q&A session.
So I don't want to take up too much time because I think there's a lot of interest, and most of that interest is likely centered on the group at Chevidence and any questions coming to the chat boxes. So just a couple of quick reactions. First, I'd like to thank Yaolong, Qi, Roman for taking the time to present all this amazing work for us at the forum. Many of us on this side of the pond or this side of the world don't have as much exposure as I think we should to the work that the Chevidence group is doing. So it's great to get that started off. I'd just like to make one observation that it's clear that the group at Chevidence are true champions and supporters of evidence-informed decision-making. And what's most impressive to me is that they're doing this across the entire spectrum from guidelines, so much effort and action around grade and developing guidelines for decision-making at the clinical level and at the level of deciding which programs, services, and drugs should be funded, all the way up to evidence-informed policymaking efforts. So that's really impressive to me that they're able to do lots of stuff across the entire spectrum. And in addition to all of this, they're supporting the efforts of others like us. So we rely heavily on the group at Chevidence to support the translation of our content and health systems evidence into Chinese so that folks on that side of the world can utilize the resource and support evidence-informed decision-making. So that's just my quick observation. Again, I think it's an honor for us to have them present all this work and really impressive stuff. The second set of observations really is kind of my reactions in terms of opportunities moving forward. I think there's lots of opportunity for us to learn from each other, and specifically experiences supporting evidence-informed policy with novel approaches. It's clear that there's a lot of similarities in their context, but clearly a lot of difference as well. So many of the issues Roman mentioned with respect to fee-for-service are things that would be familiar to people all over the world, but it's clear that there's also a lot of things going on within the group that we could learn from here, and potentially they can learn from us as well. and there has been that back and forth between McMaster Health Forum and Chevidence already. The second big opportunity, I think, is for us is learning about how to build bridges. And again, I circle back to the point I made earlier about the fact that they're doing this across the spectrum. In Canada, and in my experience anyways, is that a lot of the work with respect to evidence-informed decision-making tends to happen in pockets. So you have your people focus on clinical level decision-making in one little space, people focus on evidence-informed health systems in another, and oftentimes there's a lot of crosstalk. So I think it's really impressive that the Chevidence group seems to have built bridges across this entire spectrum in a way that's complementary to each other. So I think that that's really an important opportunity for learning for us. And finally, an opportunity to expand our own work in partnership with folks at Chevidence. There are many indexed Chinese language reviews and journals that we're currently not harvesting to include in health systems evidence. So while they're translating all of the great English content into Chinese, I think we need to at least consider and open up the conversation about how to make it possible to start harvesting Chinese language sources and then translating them into English. So those are my big picture takeaways from the talk, and I'd like to thank them again. And I'd really appreciate if we could just spend the rest of the time actually answering questions, because I see a lot are coming in. So thanks.
Thanks, Kaelan.
Yes, thanks, Kaelan. Qi, did you happen to remember the title of that publication?
Yeah, I will type on the chat box later now.
Perfect. That's great. So I guess just moving into some questions then, I see a few coming into the chat box here. Certainly if you have any others, please use a chat box to ask them as we continue. So the first question is for Roman, and just whether you could explain whether subnational governments have much decision-making authority on health systems policy, or whether such authority is concentrated at the national level. The reason for the question is that it has implications for where efforts to support evidence-informed policymaking about health systems are focused.
Thank you. This is a very important and interesting question, as it's related to which level of policy authority you need to influence for evidence-based policy making. In China, it's a central government system. However, a central government very often only gives a direction. Like they will say, we will reform the payment system, and we will change the fee-for-service. We will move in toward the direction of a bundled payment. So that's sort of the directive from the central government. However, they leave a lot of leeway, freedom for the local government to innovate and implement and pilot. Actually, the central government very often, before a policy is out, encourages the local provincial government to innovate and pilot in a way which is in accordance with the local context. For instance, when I went to Guizhou province, which is to the west of China, they are piloting many types of payment system in different municipalities. So when those pilots coming back to the provincial government, then they can think about what are the programs which will be a best fit for the entire province. Then those informations are also exchanged and gathered by the central government, and the central government also promote some of the best performing pilot sites, and there are lots of exchanges between the sites. I think this is actually part of the strength of the Chinese system. In a way, there is a overall strategic direction, but there are lots of leeway for the local government to innovate and pilot. Then there is a system which can feedback those experiments to the central government to clean out the evidence and then promote the best practice throughout the country. So in order to influence the policymakers, I think both is very important. You need to influence the central government so the overall strategic direction is set in the right direction. But in addition to that, it's also important to influence the local, provincial, or even the county, or even the township policymakers, so the implementation is there and to ensure the policy are implemented in an innovative fashion. Thank you.
Thank you very much for answering that question. That was very, very informative. So we had that question, and that was from the forum's director, John Labus, and actually we have a second sort of follow-up question from him as well, but this one is for Yaolong and Qi. Yaolong, I know your audio wasn't working, so if you have anything you'd like to add in, you can just type it into the chat box instead. So the question is that given that you're one of the few groups in the world, being the Chevidence group, that works in both the clinical space and health system space, can you comment on whether you find many synergies in doing so, particularly when it comes to supporting evidence-informed policy making about both clinical issues, for example, immunization policy, and health systems issues, for example, financial arrangements?
Yes, Steven. I think Yaolong still can't speak, but I communicated with him and we can answer the question. Thanks, John. And we would like to give an example of the flu in China. Recently, flu is very heavy in China, but for this health problem, it will coordinate the clinical aspects and the health policy or public health aspects. On the one hand, the clinicians and the Ministry of Health officials issued the diagnosis and treatment guidelines. These guidelines, including the evidence-based traditional Chinese medicine. At the same time, the Ministry of Health also conduct a lot of work in different levels. So for some public health event, the health policy and the clinical practice in China could come by together for some emergency in the national level.
Great, thanks, Qi, for answering that question. Now, if anybody has any other questions, please feel free to use the chat box to ask them. Just while we're waiting for any others to come through, I would just like to quickly mention that that we do these top 10 webinars every month. We have another one coming up on February the 8th on using evidence to take action on obesity, and it's top 10 insights from Evidencebased Estonia. So I would certainly encourage everybody to go to the McMaster Health Forum website. You can see all of our webinars listed there, and to register for those. We certainly hope that others will join us. Now, I do see a couple other questions that are coming in here. So this one is for Roman. Can you explain how the integrated system and the public health service package works again?
Thank you. For the integrated delivery system, which are currently piloted in many places of China, there are many forms of the integrated delivery system. Essentially, there are two major forms. The one in China, in Chinese, is called Yilianji. The other is called Yigongji. The difference between the two is, for the former, the organizations are loosely organized together. For instance, the county hospital may be linked with the township health center, then linked with the village clinic. However, the linkage is not mandatory, and the linkage is not the linkage of complete sharing of leadership, governance, resources, but sort of the build up of some incentive. If I refer a patient to you, and you have a green channel to receive the patients from me, and when the patient is ready to be discharged from the tertiary hospital, and the township hospital can take care of them. So, but the arrangement is loose. The other type, which is in Chinese called Yigongji, which is more closely knit relationship. However, in this integrated delivery system, the county hospital, township health center, and village clinic still maintain their autonomy in terms of organization. So they are still the independent organization. However, when they form the integrated delivery system, the government will only pay one global budget for the entire system, normally to the leadership group of the integrated group, which are very often held by the county hospital management. And also the county hospital management has some decision on the choice of the township health center leadership. they will not directly decide on who will be picked up as a head, but they have the authority to recommend the leadership candidates to the government. So they have some certain authority. And also the resources will be completely shared among the system. So the purpose is when the global budgeting is imposed on the entire system, people will think about this is the entire money I get versus the fee for service in the past, which is you do more, you get more. Now this is a fixed amount. And then you have to think about the most efficient way of dealing with that. The purpose is really to change the thinking of the county hospital to promote healthcare service, to promote health. So for instance, the hospitals we just visited 2 days ago, the integrated system in Guizhou, they actually give free treatment for hypertension and diabetes in the follow-up treatment. So the purpose is to make sure those people do not come back to the hospital. That's the sort of the thing the integrated delivery system is doing. So I hope I answered the question.
Thanks very much, Roman. That was a great answer, and we certainly appreciate that. I think that brings us to the end of our time for today's webinar. But before we go, I just really wanted to say thanks again to Roman, Yaolong, and Qi for the excellent presentations. They were very very informative, and I certainly enjoyed them. So thanks for joining us today.